Good morning, everyone. I'm Dr. Asim Hassin, and I am delighted to welcome you today. Today, we'll be going through ICU, rapid-fire revision notes. This session is designed to give you a quick yet comprehensive review of key ICU concepts. We'll cover essential topics that will help sharpen your knowledge and skills. So, let's get started and make the most of this time together. Let's talk about ARDS diagnosis first. The key measurement we look at is the PF ratio, which is the ratio of arterial oxygen partial pressure to the fraction of inspired oxygen, and this is most reliable when the PEEP is at least 5 centimeters of water. For ventilation management, we aim for a tidal volume of about 6 ml per kilogram of predicted body weight to minimize lung injury. We also want to keep plateau pressures below 30 centimeters of water to reduce barotrauma. Driving pressure, which is calculated as the plateau pressure minus PEEP, is an important concept. Lower driving pressures are associated with better outcomes. In cases of severe ARDS, characterized by a PF ratio under 150, additional strategies come into play. For example, prone positioning for at least 16 hours a day can significantly improve oxygenation. Short-term neuromuscular blockade can also be beneficial in these cases to improve ventilator synchrony and reduce lung injury. When hypoxemia becomes refractory, meaning it doesn't improve with standard measures, VV-CMO may be necessary as a rescue therapy. Interestingly, permissive hypercapnia, allowing higher levels of carbon dioxide, is acceptable as long as the remains above 7.2 to avoid further lung injury. Now, shifting gears to respiratory emergencies, understanding these foundational concepts helps us better manage critical situations, ensuring we tailor our interventions to improve patient outcomes effectively. Let's now discuss the critical signs associated with status asthmaticus, which is a severe and potentially life-threatening situation. You want to be on the lookout for signs like a silent chest, which indicates very poor air movement, as well as exhaustion from the effort of breathing. Additionally, rising PaCO2 levels can signal that ventilation is becoming inadequate. Speaking of ventilation, in these cases, you'll often see a low respiratory rate, which might seem counterintuitive, but it reflects the patient's fatigue or altered mental status. Also, a long expiratory time is typical because patients struggle to fully exhale, trapping air in the lungs. When it comes to management, IV magnesium is an important drug because it acts as a bronchodilator and can help relax airway smooth muscle. Continuous beta-2 agonists are also crucial. They provide ongoing bronchodilation to relieve airway constriction. It's essential to avoid dynamic hyperinflation during treatment, as overinflation can worsen respiratory failure. Remember, if CO2 levels start to rise significantly, that's a pre-terminal sign, meaning the patient's condition is deteriorating rapidly. All these points highlight how respiratory emergencies like status asthmaticus require prompt recognition and careful management to prevent progression to respiratory failure. When it comes to managing COPD exacerbations, it's crucial to understand when to use non-invasive ventilation, or NIV, as the first-line treatment. If a patient's blood pH is between 7.25 and 7.35, and they are experiencing hypercapnic failure, NIV is typically the preferred initial approach. It can help improve gas exchange and reduce the work of breathing without needing more invasive measures. However, there are situations where intubation becomes necessary. If the pH drops below 7.25, indicating more severe acidosis, or if the patient has a reduced Glasgow Coma Scale, meaning their level of consciousness is decreased, then invasive ventilation through intubation is usually indicated. Throughout this process, it's important to keep the target oxygen saturation between 88 and 92%. This balance helps ensure adequate oxygenation without risking CO2 retention or other complications. Remember, recognizing these key signs and understanding the appropriate interventions are vital in managing respiratory emergencies effectively. They help stabilize the patient quickly and prevent deterioration. Let's discuss some key points about pulmonary embolism in the ICU setting. When a patient presents with shock and PE, the typical approach is to consider thrombolysis, especially if the situation is life-threatening. If the patient's blood pressure remains normal, but we notice right ventricular dysfunction, that indicates an intermediate risk, and we need to monitor and manage carefully. Another critical scenario is when a patient suddenly develops a P arrest. In such cases, we must think of a massive PE as a potential cause, since it can obstruct blood flow significantly and lead to cardiac arrest. Finally, respiratory emergencies related to PE are often dramatic and urgent. Recognizing these patterns early is crucial for timely intervention and improving outcomes. So, understanding these different presentations helps us tailor our response and manage these high-stakes situations effectively. Let's talk about ventricular tachycardia and ventricular fibrillation, which are critical cardiac emergencies. When you encounter a patient in ventricular fibrillation or pulseless ventricular tachycardia, the priority is to deliver a shock immediately to restore normal rhythm. That's our first step. If the patient is in stable ventricular tachycardia, meaning they have a pulse and are hemodynamically stable, then we consider administering amiodarone. This medication helps to stabilize the heart rhythm without the need for immediate defibrillation. Now, when dealing with polymorphic ventricular tachycardia, especially in the context of a long QT interval, magnesium becomes our treatment of choice. Magnesium helps to correct the abnormal electrical activity and prevent torsades de pointe, which is a dangerous form of polymorphic VT. Throughout these scenarios, the key takeaway is that prompt assessment and targeted treatment are crucial. Recognizing the type of arrhythmia and the patient's stability guides us to the most effective intervention, which ultimately can be life-saving. This fits into the larger picture of cardiovascular emergencies, where quick, precise action makes all the difference. Let's talk about atrial fibrillation with RVR, or rapid ventricular response. When a patient presents with this condition, the management depends largely on their stability. If the patient is unstable, meaning they're hypotensive, experiencing chest pain, or showing signs of poor perfusion, then immediate electrical cardioversion is indicated to restore normal rhythm quickly. On the other hand, if the patient is stable, we often opt for rate control strategies, such as administering beta blockers or calcium channel blockers like diltiazem, to slow down the heart rate and reduce symptoms. Now, in cases where atrial fibrillation with RVR occurs in the setting of ICU sepsis, the priority shifts a bit. Here, our main goal is to treat the underlying cause of sepsis, because addressing the infection or source is crucial for overall management and stabilization. Remember, these are important cardiovascular emergencies, and recognizing the stability status of your patient guides you toward the appropriate intervention. The key takeaway is tailoring the treatment to the patient's condition, immediate cardioversion for unstable cases, and rate control for stable ones, while always considering the context, like sepsis, to guide your approach. Let's talk about cardiac tamponade, a critical cardiovascular emergency. One of the key clinical clues we look for is Beck's triad. This triad includes hypotension, which occurs due to the decreased cardiac output, raised jugular venous pressure, or JVP, because of impaired venous return, and muffled heart sounds, which happen because the fluid around the heart dampens the sound. To confirm the diagnosis, an echocardiogram is very helpful. On echo, you might see the right ventricle collapsing during diastole, which is a sign that the pressure from the fluid is compressing the heart. The mainstay of treatment here is urgent pericardiocentesis. This procedure involves draining the excess fluid around the heart to relieve the pressure and restore normal cardiac function. Remember, recognizing these signs early and acting swiftly can be life-saving in these cardiovascular emergencies. All right, let's talk about cardiogenic shock. In this situation, we typically see a decrease in cardiac index, or CI, and an increase in pulmonary capillary wedge pressure, or PCWP. This reflects the heart's inability to pump effectively, leading to poor tissue perfusion and elevated pressures in the lungs. For initial management, our first-line treatments focus on supporting blood pressure and improving heart function. Norepinephrine is used primarily to increase blood pressure by vasoconstriction, helping to maintain perfusion. Dobutamine, on the other hand, is used to enhance contractility, making the heart pump more effectively. However, if these measures aren't enough and the patient remains in refractory shock, mechanical support becomes necessary. Devices like the intra-aortic balloon pump, or IABP, Impella, or even ECMO can be life-saving by providing circulatory support until the heart recovers or other definitive treatments are performed. This slide highlights the importance of recognizing the hemodynamic profile in cardiogenic shock and implementing a tiered approach to management, emphasizing both pharmacological support and mechanical interventions when needed. These strategies are crucial in the broader context of cardiovascular emergencies, where rapid, targeted action can significantly impact outcomes. Let's talk about status epilepticus, which is a medical emergency that requires prompt and effective management. The first line of treatment typically involves benzodiazepines, such as lorazepam or diazepam, to rapidly stop the seizures. If seizures persist, we move on to second-line agents like levetiracetam or phenytoin, which help stabilize the brain activity. In cases where seizures continue despite these measures, intubation and anesthetic infusion may be necessary to control the seizures and protect the patient's brain. These steps underscore how critical it is to act quickly and systematically in neurological emergencies like status epilepticus to prevent long-term damage and improve outcomes. When managing raised ICP, or intracranial pressure, it's important to implement certain strategies to reduce the pressure and prevent further brain injury. One effective measure is to keep the patient's head elevated to about 30 degrees. This position helps facilitate venous drainage from the brain, which can help lower ICP. Additionally, administering osmotic agents like mannitol or hypertonic saline can be very effective. These agents work by drawing fluid out of the brain tissue and into the bloodstream, thereby decreasing swelling and pressure. Another critical goal is to maintain cerebral perfusion pressure, or CPP, within the target range of 60 to 70 millimeters of mercury. Achieving this balance ensures the brain receives enough blood flow without exacerbating swelling. It's also vital to avoid hypotension and hypoxia, as both can worsen brain injury in patients with elevated ICP. Maintaining stable blood pressure and oxygen levels is key to optimizing outcomes. Remember, these interventions are part of the broader management of neurological emergencies, where rapid, targeted actions can make a significant difference in patient recovery. Let's talk about some key points regarding traumatic brain injury, or TBI. First, even a single hypotensive episode can significantly increase the risk of mortality, essentially doubling the chance of a poor outcome. That highlights how crucial it is to maintain stable blood pressure in these patients. Next, we look at oxygenation, specifically, aiming for a PaO2 greater than 60 mmHg. Ensuring adequate oxygen levels is vital because hypoxia can worsen brain injury. Then, intracranial pressure, or ICP, is another critical factor. If ICP exceeds 22 mmHg, we need to treat aggressively to reduce pressure and prevent further brain damage. Finally, remember that these are neurological emergencies. Prompt recognition and management of these parameters can make a real difference in patient outcomes. So, always keep these thresholds in mind when caring for someone with a TBI. Let's talk about myasthenic crisis, which is a serious complication of myasthenia gravis. In this situation, the key features are significant muscle weakness combined with hypercapnia, meaning elevated carbon dioxide levels in the blood. One of the critical indicators we look at is the vital capacity, or VC, which if it drops below 20 ml per kilogram, signals the need for intubation to secure the airway and assist with breathing. In terms of treatment, Two main options are IVIG, or intravenous immunoglobulin, and plasmapheresis, both of which help reduce the circulating autoantibodies that are attacking the neuromuscular junction. It's also very important to avoid certain medications like aminoglycosides, which can worsen muscle weakness by interfering with neuromuscular transmission. This slide highlights that neurological emergencies, such as myasthenic crisis, require prompt recognition and intervention to prevent respiratory failure. Recognizing these key signs and understanding the treatment options are vital parts of managing patients with myasthenia gravis effectively. Let's talk about Guillain-Barré syndrome, or GBS. One of the hallmark features is ascending paralysis, meaning it usually starts in the legs and moves upward. It's important to recognize that autonomic instability is common in these cases, which can affect heart rate, blood pressure, and other involuntary functions. When it comes to treatment, intravenous immunoglobulin, or IVIG, and plasma exchange are the mainstays and have been shown to be effective. On the other hand, steroids, surprisingly, are not effective in managing GBS and are not recommended. Recognizing these neurological emergencies quickly is crucial because timely intervention can significantly improve patient outcomes. So, understanding these key points helps us identify and treat GBS effectively as part of managing neurological emergencies. When approaching a patient in a coma, the first step is always to follow the ABCs: airway, breathing, and circulation. Ensuring the airway is open and protected is critical before moving on to other assessments. Next, check the patient's blood glucose level, because hypoglycemia is a common and reversible cause of coma. If glucose is low, administering glucose can quickly improve their condition. Simultaneously, consider the possibility of opioid overdose, so administering naloxone can be life-saving if opioids are involved. Thiamine is also important, especially in cases where alcohol intoxication or deficiency is suspected, to prevent Wernicke's encephalopathy. If the Glasgow Coma Scale score is 8 or less, this indicates a severe impairment, and protecting the airway becomes even more urgent. Think about intubation to secure it and prevent aspiration. All of these steps are essential in managing neurological emergencies, where rapid assessment and intervention can make a huge difference in patient outcomes. Remember, quick identification and treatment of these underlying causes are key to improving recovery chances. Let's take a closer look at AKI, or acute kidney injury, as defined by KDIGO guidelines. An important point is that AKI can be identified by an increase in serum creatinine of at least 0.3 mg/dl within 48 hours. Alternatively, if you see a decrease in urine output to less than 0.5 ml per kilogram per hour for more than 6 hours, that also indicates AKI. These criteria are crucial because they help us recognize renal issues early, which is essential for timely intervention. When we talk about renal and electrolyte emergencies, we're essentially highlighting situations where kidney function is suddenly compromised, leading to dangerous imbalances in electrolytes or fluid status. Understanding these key markers allows us to act swiftly, preventing further deterioration and improving patient outcomes. Remember, early detection and management are the cornerstones of handling these emergencies effectively. Let's take a closer look at dialysis and the AEIOU mnemonic, which helps us remember the key reasons for renal and electrolyte emergencies. First, acidosis. This occurs when the kidneys can't eliminate acid effectively, leading to a buildup of hydrogen ions and a decrease in blood pH. It's crucial to recognize this because severe acidosis can impact multiple organ systems. Next, electrolytes, especially potassium or K+. Elevated potassium levels are common in renal failure and can cause dangerous cardiac arrhythmias, so monitoring and management are vital. Then, ingestion. Sometimes, patients may ingest nephrotoxic substances or excessive electrolytes, which can precipitate emergencies. Overload refers to fluid overload, when the kidneys can't handle fluid removal, leading to pulmonary edema or hypertension. Lastly, uremia. This is the buildup of urea and other waste products in the blood, causing symptoms like fatigue, nausea, and altered mental status. Connecting all these points, the AEIOU framework helps us quickly identify and address the most critical renal and electrolyte emergencies. Recognizing these signs early can make a huge difference in patient outcomes and guides our intervention strategies effectively. Let's talk about hyperkalemia and why it's so critical to recognize quickly. When you see ECG changes suggestive of hyperkalemia, it's a sign that we need to act immediately. These changes can include peaked T waves, widened QRS complexes, or even sine wave patterns, all of which indicate dangerous levels of potassium in the blood. The first step is to stabilize the cardiac membrane, and for that, we use calcium gluconate. It doesn't lower potassium levels, but it helps protect your heart from the effects of high potassium. Next, to actually lower the potassium, we administer insulin along with glucose. The insulin drives potassium into the cells, reducing serum levels, and the glucose prevents hypoglycemia. Beta agonists like albuterol can also be effective. They work by shifting potassium into the cells as well. If the hyperkalemia is refractory to these measures, or if the patient is critically ill, dialysis becomes necessary to remove excess potassium directly from the bloodstream. Remember, in renal and electrolyte emergencies like this, rapid recognition and intervention are essential to prevent life-threatening complications. Let's talk about hyponatremia, which is a common electrolyte imbalance we encounter in clinical practice. When it's acute and symptomatic, the priority is to correct the sodium level carefully. Typically, we use 3% saline solution to raise the serum sodium, but it's crucial to do this gradually. The recommended correction rate is no more than 8 to 10 mmol per liter per day to avoid complications. Now, one of the most serious risks associated with correcting hyponatremia too rapidly is osmotic demyelination, which can cause severe neurological damage. That's why careful monitoring and controlled correction are essential. This slide fits into the broader theme of renal and electrolyte emergencies, where precise management can prevent life-threatening complications. Remember, balancing correction speed with safety is key in managing these critical situations. Let's talk about septic shock, which is a critical condition that requires prompt recognition and management. One of the key targets in managing septic shock is maintaining a mean arterial pressure, or MAP, of at least 65 millimeters of mercury. Achieving this helps ensure that vital organs are adequately perfused. Lactate-guided resuscitation is also essential. Elevated lactate levels can indicate tissue hypoperfusion, so we use lactate measurements to guide our resuscitation efforts and assess how well our interventions are working. When it comes to vasopressors, norepinephrine is our first choice. It's effective in restoring blood pressure without causing excessive vasoconstriction that could compromise organ perfusion. And of course, early antibiotic administration is crucial, ideally within the first hour of recognizing septic shock. Prompt antibiotics help control the infection that's driving the entire process, and early intervention can significantly improve outcomes. So, in summary, managing septic shock involves maintaining adequate blood pressure, guiding fluids and vasopressors with lactate levels, choosing norepinephrine as the first vasopressor, and administering antibiotics promptly. These are key steps in addressing infectious emergencies like septic shock. Neutropenic sepsis is a critical emergency that requires immediate action. When you suspect it, the first step is to treat without delay. The cornerstone of initial management is administering a broad-spectrum anti-Pseudomonal beta-lactam antibiotic. This is essential because Pseudomonas can be a common and dangerous pathogen in neutropenic patients. It's important to remember that even a fever alone in this context is considered an emergency. It warrants urgent intervention because the immune system is compromised, and infections can escalate rapidly. This slide falls under the broader category of infectious emergencies, highlighting how quickly infections can become life-threatening if not addressed promptly. So, in summary, Any signs of neutropenic sepsis demand immediate treatment with the right antibiotics, and never underestimate the significance of a fever in these patients. Rapid recognition and response are key to improving outcomes. Let's talk about thyroid storm, a life-threatening condition that requires prompt recognition and management. The Birch-Wartofsky score is a helpful tool here. A high score indicates a severe thyroid storm and the need for urgent treatment. The treatment order is crucial. First, we start with a beta blocker to control the adrenergic symptoms like rapid heart rate and tremors. Next, we administer PTU, or propylthuracil, because it helps block new thyroid hormone synthesis. After giving PTU, we add iodine, but it's important to do this only after PTU because iodine can actually fuel hormone production if given first. Then, we administer steroids, which help reduce hormone release and also address any potential adrenal insufficiency. Remember, these steps are part of managing the endocrine and metabolic chaos that occurs during a thyroid storm. The key is to act quickly, follow this sequence, and stabilize the patient effectively. Let's talk about myxedema coma, which is a severe complication of hypothyroidism. It typically presents with a combination of hypothermia, bradycardia, and hyponatremia. These signs indicate that the body's metabolic processes are critically slowed down. The treatment for myxedema coma involves administering IV levothyroxine, which is a synthetic form of thyroid hormone, to quickly restore thyroid function. Additionally, hydrocortisone is given to address potential adrenal insufficiency, which can coexist and complicate the condition. It's important to recognize that this condition carries a high mortality rate, so prompt and aggressive treatment is essential. This topic ties into the broader theme of endocrine and metabolic emergencies, where rapid recognition and intervention can be life-saving. When managing severe hypoglycemia, the first priority is to administer an IV dextrose bolus to quickly raise blood sugar levels. It's crucial to ensure rapid correction to prevent neurological damage. If the patient is malnourished or has a history suggesting possible thiamine deficiency, I always give thiamine before glucose. This step helps prevent Wernicke's encephalopathy, which can occur if thiamine deficiency is present and glucose is administered first. In the context of endocrine and metabolic considerations, understanding these steps is vital because they address not just the immediate hypoglycemia, but also underlying deficiencies that could complicate treatment. Remember, the key points here are to give dextrose promptly and to consider thiamine supplementation in malnourished patients. These actions are essential parts of a comprehensive approach to managing severe hypoglycemia safely and effectively. Let's talk about TCA overdose and what to watch for. When dealing with a TCA overdose, one of the key signs on the ECG is a QRS duration greater than 100 milliseconds. This can actually lead to seizures, so it's a critical point to recognize early. In terms of treatment, administering intravenous sodium bicarbonate is the mainstay. It helps to narrow the QRS complex and counteract the cardiotoxic effects of the overdose. It's also important to remember to avoid using Class I antiarrhythmic drugs in these cases, as they can worsen the situation. Understanding these toxicology emergencies is vital because prompt recognition and treatment can be life-saving. So, always keep an eye on the ECG and be prepared to act quickly with the right interventions. Let's talk about salicylate poisoning now. In this situation, you often see a combination of mixed respiratory alkalosis and metabolic acidosis. This happens because the salicylates initially stimulate the respiratory center, leading to rapid breathing and respiratory alkalosis. But as the poisoning progresses, metabolic acidosis develops due to the accumulation of acids and disrupted metabolic processes. One of the key treatment strategies here is urine alkalinization. By making the urine more alkaline, we can enhance the elimination of salicylates through the kidneys. Additionally, dialysis becomes necessary if certain severe conditions are present. These include altered mental status, which indicates significant CNS involvement. severe acidosis that can't be corrected with other measures, or pulmonary edema, which can compromise breathing further. Remember, these are critical points in managing salicylate toxicity, and prompt recognition and intervention can be life-saving. This ties into the broader theme of toxicology emergencies, where quick, targeted actions are essential to improve patient outcomes. Let's talk about carbon monoxide poisoning. One key point to remember is that normal SpO2 readings can be misleading in these cases. That's because pulse oximetry can't differentiate between oxygen and carbon monoxide bound to hemoglobin. So, even if your SpO2 looks okay, the patient might still be severely hypoxic. To accurately diagnose co-poisoning, you need to measure the carboxyhemoglobin level, or COB. This is the definitive test and helps confirm the extent of poisoning. Now, when it comes to treatment, hyperbaric oxygen therapy is indicated in certain situations. Specifically, if the patient has neurological symptoms, is pregnant, or if the COB level is 25% or higher. These are critical thresholds because they indicate a higher risk of severe toxicity and potential long-term consequences. Remember, in toxicology emergencies like these, prompt recognition and appropriate intervention can make a huge difference in patient outcomes. Let's talk about methanol and ethylene glycol poisoning. When someone is exposed to these substances, we often see a high anion gap and a high osmolar gap in their labs. These are key clues that point to these toxins. The high anion gap indicates metabolic acidosis, while the elevated osmolar gap suggests the presence of an unmeasured osmol, like methanol or ethylene glycol. In terms of treatment, the antidote of choice is fompazole. It works by inhibiting alcohol dehydrogenase, the enzyme responsible for converting these substances into their toxic metabolites. If the poisoning is severe, dialysis is often necessary to rapidly remove the toxins from the bloodstream. Understanding these toxicology emergencies is crucial because prompt recognition and treatment can significantly improve outcomes. So always keep in mind the characteristic lab findings and the appropriate antidotal therapy when managing these cases. Let's take a closer look at some of the key signs of organophosphate poisoning. You might see symptoms like diarrhea and diaphoresis, which is excessive sweating. Urination can also increase, along with pinpoint pupils, known as meiosis. Patients may experience bradycardia, which is a slow heart rate, and bronchospasm or bronchoria, meaning narrowing of the airways and excessive mucus production. Vomiting, lacrimation, or tearing, and increased salivation are also common. All of these symptoms are collectively summarized by the mnemonic DUMBBELSS, which helps us remember the main features of organophosphate poisoning. This condition results from acetylcholinesterase inhibition, leading to an accumulation of acetylcholine and overstimulation of parasympathetic nervous system receptors. In terms of treatment, the mainstays are atropine and pralidoxime. Atropine helps block the excess acetylcholine at muscarinic receptors, alleviating many of these symptoms. Pralidoxime works to reactivate acetylcholinesterase, revealing the underlying cause. It's crucial to remember that if not treated promptly, the cause of death in these cases is often respiratory failure. The excessive secretions, bronchospasm, and muscle weakness impair breathing, making early recognition and intervention vital. So, in summary, understanding these signs, the mnemonic DUMBBELSS, and the appropriate use of atropine and pralidoxime can make a significant difference in managing organophosphate poisoning effectively. Let's start with intubation, which can actually be quite risky in cases of tricyclic antidepressant overdose and salicylate poisoning. It's important to remember that intubation in these scenarios can sometimes do more harm than good, so weigh the risks carefully. Next, when we talk about shock, the key causes to think about are tamponade, massive pulmonary embolism, and tension pneumothorax. These are critical conditions that can present with shock, and recognizing them quickly can be life-saving. Moving on to asthma, if you notice a rising PA-CO2 level, it's a warning sign. It indicates that the patient is tiring out and that impending respiratory arrest may be on the horizon. Don't ignore that trend. It's a red flag. Now, hyperkalemia is a tricky one. The ECG changes often appear more rapidly and are more pronounced than what the lab number might suggest. So, always pay close attention to those ECG clues. They can be life-saving. Lastly, hyponatremia requires careful correction. It's not just about bringing sodium levels back to normal. The speed at which you correct hyponatremia is often more important than the actual level. Correct too fast, and you risk causing osmotic demyelination syndrome. And to wrap up, these final pearls highlight the importance of understanding these nuances in emergency management. Recognizing these subtle but critical signs can truly make the difference in saving lives. Thank you so much for your attention today. I really appreciate your time and engagement. We've covered quite a bit, from the key concepts to the practical applications, all tied together by the main theme of innovation and growth. I hope you found the insights valuable and that they inspire you to take action in your own work. Remember, the ideas we've discussed are just the beginning, and I encourage you to explore them further. Once again, thank you for being part of this presentation. I look forward to seeing how you apply these concepts moving forward.